Good evening, everybody, and welcome to our seventh and Meet the Consultant. Tonight, we've got Louisa, who is our captioner, and she's going to obviously capture what we're saying so you can read what is happening. So if you want to know how to join that, please look in the chat, and then therefore you'll be able to get the information about how to see what Louisa is typing. So welcome. Obviously around the screen, we've got John Pierce, obviously one of our trustees, treasurer, and obviously vice chair of TOFs. And we've got Nick Maynard, who is well known to a lot of people, but those of you who don't know, he's obviously from Oxford University Hospital, and obviously consultant upper GI surgeon. So thank you for joining us. Can I please just add one thing? If you are watching this back on YouTube afterwards, please remember to like us in the top corner and obviously subscribe, because then when we do more of these in Meet the Consultants, you can obviously look back and look at some of the other videos, or you can be, as soon as we launch one, obviously you'll get those up to date. Now, we do have lots of questions tonight. We've got 32 questions at the moment. So we are going to say that obviously the chat room, please try not to use it, because of course we need to get through all these questions that we've already been submitted prior to tonight. If we do get a chance, we'll ask them, but I'm not going to promise anything because we will finish at 8 o'clock without fail. So without further ado, I'm going to hand over to John, and obviously we'll get going with the questions. Thanks, John.
Hello, everyone. Good evening, and good evening, Mr. Maynard. So we've got a list of questions which we're going to ask Mr. Maynard, and I'm going to start off with the first set, which are mostly about reflux. So question number one, why do patients who were born with TOF and OA have such horrendous problems with reflux? And can you explain why TOF OA adults develop silent reflux?
Yeah, hello everyone. It's a great pleasure to be here. Yeah, I hope I can sort of help with a lot of these questions. So patients who have been born with esophageal atresia, with or without a fistula into the trachea, are always prone to getting problems with their esophagus throughout their life. It doesn't mean they all do, and quite a few don't, but they are more likely to get problems specific with reflux. And there are two main reasons why that's the case. The esophagus beyond the repair, so the esophagus belong the atresia that's been repaired, it doesn't have a proper nerve supply because the nerves haven't developed properly, and therefore it doesn't contract as well as it should do. That alters the way that the valve or the sphincter at the bottom of the esophagus works, and it can allow acid to come up into the esophagus. But also, because the esophagus doesn't contract properly, because the nerves aren't functioning properly, any acid that does come up is very slow to be cleared again. So it hangs around for much longer. The other reason is that there is a much greater risk of having a hiatus hernia if you've had an esophageal atresia repaired, because there is almost inevitably some shortening of the esophagus. And when that happens, that often means that the top of the stomach rides up through the diaphragm, so it's sitting in the chest, and a lot of the structures around the diaphragm help prevent reflux. So if you have a hiatus hernia, it makes much more likely that acid and food is going to come up. So those are the two main reasons: the lack of innervation of the esophagus and the presence of a hiatus hernia.
Okay, thank you.
And I guess, sorry, one other thing, John, just about the silent reflux. It's a really good question, that, because silent reflux is very well established to be a problem, and that's because the esophagus below the repair has relatively reduced sensitivity, so it won't tell you there's acid coming up because the sensation is less than it normally is.
Okay, that's interesting. Thank you. Number two, it's not so obviously falling into your area of greatest interest, but what are the long-term risks associated with aspiration caused by TOF or an OA?
Yeah, no, you're absolutely right, John, because they're often seen by respiratory physicians, but there's a big overlap, of course, because a lot of people who've had a TOF may get respiratory problems, and that can be caused by reflux. And that what happens is the reflux of the acid, the fluid, the food even comes back up the esophagus and spills over into the lungs. And I see a lot of people for whom that is a significant problem. And it's one of the reasons why we do sometimes operate on people to stop that happening. That can cause recurrent chest infections needing antibiotics, occasionally pneumonia. It can worsen asthma if you've got asthma by what's thought to be perhaps silent reflux at night and exacerbating the asthma. And very occasionally, but I mean really rarely, it can cause quite significant lung disease, such as bronchiectasis or something like that.
Okay, thanks. That's helpful. So the third question that we have, trying to move on reasonably quickly through this long list, a bit about risks and benefits associated with taking, or indeed not taking, any medication, or maybe even having regular medical checks for OA, and in particular issues related to OA, such as reflux.
So I think that sort of, really is core to so many of the discussions we have about problems with reflux. It's the risks and the benefits of any interventions. I'll answer the second bit first. I think regular medical checkups are important, and probably the most important thing at some stage is to have an endoscopy. If you're someone with no reflux, no swallowing problems, and really no problems at all, then clearly you don't need to have anything done. But if you do have reflux, at some stage, I would suggest that in young adulthood, it would be sensible to have an endoscopy just to see what the esophagus looks like, and to make sure there's no Barrett's esophagus, which is a condition where the reflux can damage the cells. If you haven't, then it means you may need another endoscopy in 5-10 years' time, but you don't really need to have them more frequently than that. If you have got Barrett's, then you do need to have more regular endoscopies, probably every 3 years. The risks and benefits in terms of taking medications or having any other treatment, well, every treatment does have a side effect or a risk. So drugs aren't, there's no drug without any side effects at all or any risk. But the proton pump inhibitors such as omeprazole or lansoprazole are, compared to many other drugs, really very, very safe. And if your symptoms are really affecting your quality of life, then it absolutely is worthwhile taking medication in order to treat them, because the benefits significantly outweigh the risks. And that really is the criterion we use for any treatments, whether we consider surgery or drugs. What are the benefits? What are the risks? And get that balance right, so we can then do the right thing.
Okay, that's very helpful. Thank you. So next we have someone who has out of control reflux on high dose esomeprazole at present. What can you suggest? Do you have any advice for this?
So yeah, I mean, it follows on very well from that last question, doesn't it?
Yes,
So if
yes,
you're
it
on
does.
high dose esomeprazole to control the symptoms, if it controls the symptoms absolutely perfectly, then maybe all you need to do is stay on the esomeprazole. But if you're saying out of control, that sounds like you're on a lot of esomeprazole and you're still getting reflux. And that really does need, it ought to be investigated further. And that's the sort of patient I would always welcome seeing, and people who specialize in the same area as me would welcome seeing as well. And that would mean we would investigate with an endoscopy. We might do some tests to measure the amount of acid. But as a very general rule, if the drugs are not controlling the reflux and it's significantly affecting your quality of life, that is when sometimes we do consider keyhole surgery to try and correct it. So the advice is you should get some professional advice and go and see someone who can investigate appropriately, and then talk through the options for managing it better than it is.
Okay, that's very helpful. Thank you very much. Perhaps we should jump to question 6 at this point, because that's very, very similar. Someone's asking, what options are there for adult TOFs who have severe reflux if they've got an esophagus that isn't functioning particularly well?
So we would always try and manage it clearly with medication, and so it depends what medication you're on. The previous question included esomeprazole, and that to me is the best drug there is. So if you're not on that, if you're on something else, I would always recommend a trial of that. It doesn't mean it's always going to work, but generally it's better than the other drugs in my experience. So I'd certainly consider that. I mean, one should never forget lifestyle changes and, you know, and those and modifying your diet. But if you've tried all that, esomeprazole doesn't work and you've got bad reflux, then we would do some tests to measure the amount of acid reflux, and occasionally keyhole surgery can help. It's again comes back to the issue of risk versus benefit, because having the lower part of the esophagus, which doesn't contract very well, can increase the risk of side effects from the surgery. So we always take those things into account. But essentially, if the reflux is very poorly controlled, one option is to consider investigating to see whether any keyhole surgery might help with it.
Okay, thanks for that. And at what point might you consider reflux or regurgitation to be poorly controlled and requiring intervention, therefore?
I mean, I think it's really what the patient's experiencing. I think it's what their symptoms and their quality of life. So if you get just very occasional acid reflux and it's just a nuisance if you eat the wrong things or drink the wrong things or whatever, then it may be that it's something you're prepared to put up with, because the alternative of having surgery or something may not be very attractive. But if it's hugely affecting your quality of life and it's stopping you working, stopping you socializing, stopping you sleeping, then there's not necessarily reason why you should be like that. And that certainly should be investigated. Not everyone would benefit from surgery. It's very important people understand that, but you should at the very least have an assessment to see whether surgery might be appropriate or whether we can just improve things with medication. But essentially it's about quality of life.
Okay, that's helpful, thank you. Well, the last question we have in this section, we've got quite a lot of stuff from a lady who's the mother of a TOF who's nearly 20 years old. But the question seems to boil down to, should this person now be getting regular checkups, and how often should he have a camera down? In other words, an endoscopy, as you were mentioning earlier.
Yeah, so I mentioned a bit about that earlier, didn't I? I have a very low threshold for doing endoscopies in anyone with bad reflux, whether they're a TOF patient or not, because I think that the people do get silent reflux. We know reflux can damage the lower esophagus, so anyone with bad reflux should get an endoscopy. Now, if that endoscopy shows no damage to the esophagus, and in particular no Barrett's, then you wouldn't need to have another endoscopy perhaps for another 10 years. I would probably recommend, if you're still having regular reflux, every 10 years. If you have got Barrett's, then that would need to be kept under surveillance with regular endoscopies every 3 years usually.
Okay, well, that's helpful. Well, I'll shut up for a few minutes now and pass over to my colleague Duncan with some further questions about a slightly different subject. Thanks.
Thanks, John. So next question. I'm taking formitidine, a replacement for ranitidine, due to awful lot of bloating. I can only take it once a day, and I'm finding that my stomach is not emptying well at all. I moved to a main meal at midday, anywhere between 12 and 4, and depending on the activity, which has worked in lockdown, but obviously now inconvenient in real life. Is there something else that they can do?
Yeah, so that's a difficult problem, isn't it? So it sounds like if the stomach's not entering well, it sounds like the muscles in the stomach perhaps might not be functioning quite as well as they should do. So and that often makes reflux worse. If the stomach's not emptying, there's more stuff to reflux back up, and that can make the symptoms worse. So, I mean, there are some medications which can help improve the way the stomach empties, and they will also help with reflux. And the most common drug is something called metoclopramide. You may have heard of that, or Maxilon. And there's also another drug called domperidone. There is a really good drug which is an antibiotic called erythromycin, which can help as well. So certainly drugs can help improve the way the stomach empties, and you should go and talk to your GP about that. Occasionally, and I have seen this in a handful of patients who've had TOF repairs, the stomach can be really very slow to empty, and that's a condition called gastroparesis, when the stomach is partly paralyzed. And there are some tests we can do to see whether there's any evidence of that, and that is doing a gastric emptying study. So my advice is probably just to try some simple medication and see if that helps. If that doesn't work and it's a real problem, then perhaps see your doctor and ask to be referred for consideration of investigations into the possibility of gastroparesis.
Okay, that's great. Thank you. So next question. I'm 52 and only just recently started taking PPI when I started suffering with heartburn and acid reflux. I have medical trauma from invasive procedures. Would you recommend an endoscopy or just actually keep taking the PPI for infinitum?
So I would recommend an endoscopy. I know they're not very nice, and I really do recognize that they're a bit unpleasant at times. But I think if you started having reflux in your early 50s, I would strongly recommend an endoscopy just to see what the state of play with your esophagus is. See if you've got any Barrett's. See if there's anything else going on, because sometimes other problems can present with reflux type symptoms, and it would be very reassuring to know there's nothing else going on. I know endoscopies aren't very nice. They really, I mean, all units will offer sedation, or most units should offer sedation for them, but you should certainly ask for that. And with appropriate sedation, you should be able to have it done without any difficulties at all, because you'll be, it's not a full anesthetic, but it makes you very dopey. So I would certainly ask to be sedated for that.
Okay, that's good advice.
But I would recommend you have an endoscopy.
Okay. Next question. My daughter's 14 years old and is a double TOF with a long gap at birth. She's needed anti-reflux medicines for a lot since while growing up, and used to be really sick as a baby and then started growing up as a young child. Should she continue taking the omeprazole tablets when she's starting to feel struggle, because she's not taking it that much now?
No, I mean, I'd probably be guided by her symptoms, actually. If she's not getting many symptoms, then there's no need to take it regularly. I mean, these drugs do have side effects. They're very safe, but I'd be guided by her symptoms. And even though the drugs are officially licensed to be taken regularly, actually taking them on an intermittent basis is fine. And I advise many of my patients to do that. So it would be fine just to tailor it according to her symptoms, really.
Okay. And last question for me before I pass back to John. I'm 64 years old and been taking omeprazole 20 milligrams for 11 years. I've tried to reduce this, but it only lasts for a few days before the reflux kicks back in and my health deteriorates. Should I be mindful of like minerals and vitamin malabsorption? And I see myself needing a dose of certainly of omeprazole for the rest of my days.
Yeah, that's a good question, and I do get asked that quite often. There is some evidence that these drugs can reduce the absorption of some essential minerals and vitamins. So but these are rare. So there is a risk of change in magnesium levels. It's in 25 years being a consultant, I've seen that once. So it's vanishingly rare. What is more common is osteoporosis. Now, I don't know whether the question is male or female, but there is a risk of osteoporosis in ladies following the menopause, and that is a real risk. And therefore, if you're worried about that, it'd be quite easy to firstly have a set of blood tests done by your GP to measure calcium levels and vitamin B12 levels and iron levels. But also you can have something called a DEXA scan, which measures the density of the bones and will tell you whether there's any evidence of osteoporosis. And if you're at 64 and the reflux isn't well controlled by esomeprazole, I'm not quite sure, is it only when you reduce it? But I mean, there's always an option of considering other interventions such as keyhole surgery. We're generally pretty cautious about offering this surgery, but it's sometimes at the very least worth a discussion about it.
Okay, Thanks for that. John, back to you.
Okay, thank you. Well, we'll move on now to go through some of the questions we've had sent in about strictures and then Barrett's esophagus. So firstly, there's someone who's thinking ahead. A child is relatively young at the moment and is asking how many strictures in adulthood would be typical when an intervention is needed for a stretch or a stricture, or is stretch or stricture typically childhood issues?
They're much more common in childhood, and I find that most people I see have had quite a few dilatations in childhood, but they're much less common in adulthood. So I clearly only see the ones who've had problems, so I don't see the ones who don't have problems. So by definition, in many ways, I think that there is a minority of adults who get these problems, but those I do see typically have a stretch by me maybe once every year or two. It's uncommon. They're usually very mild strictures and they only need very occasional dilatations. It's really very uncommon to see really bad strictures in adults.
Okay, that's helpful. And what are the signs of a stricture in an adult? Do people go through their adult life without any?
No, I mean, if it's a significant stricture, then it causes swallowing problems. So when you swallow, particularly meat or hard foods or dry foods, you will notice that it sticks. And if you can see me pointing, obviously everyone's anatomy is different, but the usual area is somewhere in the middle of the chest, and you might find food sticking as it goes down. If it's bad, then the food may get stuck, and you may have to vomit it back up. But if a stricture is significant, those are the symptoms it would cause.
Okay, well, thanks for that. So we'll move on to some of the questions we've had sent in that particularly address Barrett's esophagus. So you've mentioned that several times already, so there may be some repetition here. Yeah. Somebody's recently been diagnosed with a word I can never say, eosinophilic esophagitis, which we note is slightly more common in TOF people than in the wider population. Is there anything that this person needs to be aware of, having been diagnosed with this? Does it increase risk of Barrett's, for instance?
No, is the short answer. I mean, there is thought to be an association between eosinophilic esophagitis and patients who've had TOFs. It's a rare association. Eosinophilic esophagitis is a rare condition. I see it in other patients. I've never seen it in someone who's had a TOF, but there is thought to be a slightly increased risk. What eosinophilic esophagitis is, as I said, it's an uncommon condition. It's an inflammation affects the lining of the esophagus, and it's thought to be due to an allergic reaction. And one of the possible reasons why it's slightly increased risk in TOFs is because food is slower to go down the adult esophagus in a TOF than otherwise, and therefore there's perhaps a longer time when the food is in contact with the lining of the esophagus and can cause an allergic reaction. But I really would stress it's a very uncommon condition. It doesn't increase the risk of Barrett's. And most importantly, when eosinophilic esophagitis is treated, then it can be treated very successfully and goes and doesn't necessarily come back. So it certainly isn't going to make you more at risk of Barrett's.
Okay, that's good to know. And there's a sort of follow-up from this same person. As an adult TOF, am I at risk of Barrett's if I don't take PPIs?
No, there's no evidence at all that if you haven't got Barrett's, that taking PPIs will reduce the risk of Barrett's. So we do treat, if you have got Barrett's, we do recommend PPIs, but I think it's sensible, if you're refluxing, to have a one-off endoscopy just to see if there is any Barrett's. But if you haven't got Barrett's and your symptoms aren't bad enough to need regular medication, then I wouldn't recommend you go on to PPIs just to prevent Barrett's, because it doesn't work like that.
Okay, that is helpful. Thank you very much. And I think we've probably addressed this one already, but tell me if that's the case or not. How often is an esophagram recommended? Should biopsies be taken?
So an esophagram is actually an X-ray rather than endoscopy. So I wonder whether the question is meaning an endoscopy rather than an esophagram, because you can't take biopsies at an esophagram. So an esophagram is another word for it, is a barium swallow.
Yeah.
I do them quite often in the patients I come to because it's really helpful at working out the anatomy, but it would be very unusual for it to be done in general practice, and I only do it in patients who've got real problems with their esophaguses. In terms of the biopsies, I suspect the question was probably meaning an endoscopy rather.
I suspect that too.
Yeah. So yes, if there is Barrett's, you should absolutely biopsy it to see if there's any further changes, and if you've got any suspicion of eosinophilic esophagitis, then we should that's diagnosed at biopsy as well. So my rule of thumb really is for anyone who's got some swallowing problems related to this, I would take biopsy of the esophagus, yes.
Okay, that's helpful. Thank you. Well, I think that's time for me to pass back to Duncan again.
Yeah, I'm going to carry on. Questions on surgery now. Are you aware of anyone with experience of undertaking repairs or replacements of the colon interposition in the UK? And this person lives in Scotland.
So, I mean, yes, I do it myself. And I have operated on people with colon replacements, which have been put in, who have been for a repair of a long apatresia. So I think most esophageal surgeons, it's a relatively small specialty in the UK, but most people who do regular esophageal surgery, or most centres, shall I say, that do regular esophageal surgery, will have one or two people who will regularly use the colon to reconstruct the esophagus, or will do revisional surgery on the colon that's been previously put up there. There aren't many people who take that on, but there will be enough people around the country who would be doing that. But I think the numbers who do it in TOF patients are fairly limited, and I'm one of them.
Okay, thanks for that. I've been told it's too risky to have any further corrective surgeries. Is there anything further that can be done? And this person's 35 and born with a long gap.
Yeah, I mean, I guess it's difficult to know without really knowing the details of your case, but we do sometimes say an operation is too high risk. I mean, I guess it's impossible to comment on your particular case, but as I said earlier in the session, any decision to operate is also always a balance of risks versus benefits. And if your symptoms are terrible, you know, massively affecting your quality of life, then it may be that it's worth a risk of major surgery. What I would say that if you're being told that by someone who doesn't regularly do that surgery, it would probably be worth getting an opinion from someone who does do this surgery regularly, because they'll be the best people to tell you what the risks are and what the likely benefits are.
Brilliant, thanks. Are there any considerations to be made if you've had a fundoplication performed, i.e. what are the higher risks?
I guess, is that implying with a review to doing more surgery? I suspect it is.
Yeah, that's the way I've read it.
Yeah, so I mean, yes, it is. But I mean, if you've had surgery before, then any subsequent surgery is always higher risk. It doesn't mean it's very high risk. It just means it's slightly higher risk than before. And it's similar to my previous question, I guess, the two questions before, that people who regularly operate in this area, an upper GI surgeon like myself, an esophageal surgeon myself, they will do operations on people who've had surgery before. Some of us specialize much more than others. And that's something that you build up over years, really. So I do a lot of surgery on people who've had previous fundoplications, and although it is sometimes more difficult and can be take quite a bit of time, the risks are still broadly fairly low considering what you're doing. So, but again, it depends on who's doing it, and with all these things, it's terribly important to have someone doing it who does it regularly and knows what they're doing, because that really will reduce the risks.
Okay, thanks for that. John, it's back to you.
Gosh, I seem to have ended up with more questions on this occasion, don't I? So there's a miscellaneous ragbag of various different questions here, but I think many of them roam over the territory we've already roamed over. So please give us a short answer if that's appropriate, Mr. Maynard.
Yeah.
So first one relates to somebody whose grandson is now just about 20. Has had all kinds of traumatic childhood, including not only a TOF OA repair, but also a Nissen's fundoplication, gastrostomy, and an aortopexy. But he's now, over the last couple of years, starting to have severe retching attacks. These started after his Nissen's, which was done a long time ago. I mean, is it normal, is the question really, 20 years after surgery, to have such retching attacks coming back?
I wouldn't say it's normal, no, but I mean, I think people who've had this sort of surgery do not infrequently get symptoms like this. It's a bit difficult to know what it's due to. I mean, there are various things that's going through my mind. Certainly people who've had a Nissen's, it's often quite tight around the lower esophagus, and therefore food can sometimes get stuck if you rush your food or if you eat the wrong thing. So if they're getting recurrent retching attacks, it makes me think maybe something's getting stuck. Obviously, this is a bit complicated with duodenal atresia and malrotation, so there can be problems perhaps with the duodenum and lower down. But and if he's had a colonoscopy, gastroscopy, and X-rays, that the tests that are usually most helpful. I mean, again, it's difficult to know with certain because I don't really know the case very well, but it's often quite useful. This is one of the circumstances when I find doing a barium study really, really helpful. And that involves swallowing some barium and then having X-rays, watching it go down through the esophagus, through the stomach, and even through the duodenum and intestine. And that can really, so it's a dynamic investigation. You can watch things going through and you can see if it's a little bit tight. The other test that sometimes is really good at looking at the duodenum and the small bowel, if he's had atresia, is an MRI scan of the bowel. That can be really useful. So it's I guess it's coming. I'll say again what I've said already, that what would be really important is that your grandson is investigated by someone who's familiar with these problems and knows what tests to do and knows how to interpret them. Because if they're being investigated by just a general, I'm sure very, very good doctor, but who's not experienced in these problems, they may not know what the tests to do are. So those are my thoughts, but I would make sure they're seeing someone who actually understands this area really well.
That sounds very reasonable. Thank you for that. Okay, we've got the next question on our list. Is about, in a way, discharge. This one's very simple, actually. It amounts to, the son is 20, he's never had a follow-up, was discharged at the age of 18, he's got some problems with food going down now. How can he see a consultant?
So he should see a consultant. He should get your GP to refer you in. And I would say your son needs an endoscopy and possibly a barium swallow as well. I mean, my default way of investigating people who come to see me in this situation is I nearly always do an endoscopy and get a barium swallow, and that gives me a really good picture of what's going on. There's often we might do other tests as well, like the 24-hour acid studies or manometry, but from what you've said, I would go and see your GP and ask to be referred to an upper GI specialist who ideally is used to seeing people who've had TOFs, but if not, certainly an upper GI specialist.
Okay, that's helpful. Thank you very much. Well, now we've got a question from one of your previous patients, or for our current patient, who says he met you in December 2019, asked a lot of questions. Nothing remarkable has happened since, which is good. However, this person finds they can't eat onions or garlic or similar things, as it feels like it's burning inside of me and feels physically hot. He's had several tests and a scan on gallbladder and liver. All of these are fine. Could it just be a food allergy?
Well, yes, it could be. I mean, some people do get intolerances to food, even if it's not a true food allergy. I mean, if the burning's in your chest, it could all be acid reflux. And certainly that's the most typical symptom of acid reflux is burning. So If it's burning in your tummy, then it may just be some gastritis related to acid and the food you're eating. So people are intolerant to some foods. So it may be that I mean, it's difficult to tell, but if the burning is in your chest or stomach area, it might be appropriate to have an endoscopy. And I can't tell who you are, but you're very welcome to come back and see me.
Okay, that's good. Thank you. Yeah, again, it's a case of something seems to be materially wrong, then get seen.
Yeah.
Yeah. Okay. So next question, what medicine is recommended to help adults with slow stomach emptying?
So I mentioned this briefly earlier. So metoclopramide is helpful. Domperidone is helpful. And a really good one is an antibiotic called erythromycin. We sometimes do. I do sometimes do an endoscopy and do a balloon stretch of the bottom of the stomach, and that can help sometimes. And that I stretch the valve, the sphincter, called the pylorus, which is the junction between the stomach and the duodenum. And we sometimes inject Botox into it as well.
Fair enough. Okay. Let me see. That's a very helpful response. But something else we could ask now about surveillance program for adult TOFs, of which there is one in the Netherlands. Adults over 30, this person believes, are offered an OGD with Lugol staining every 3 years. Do you think that's a sensible approach? And should adult TOFs in the UK be trying to seek this sort of follow-up?
We don't do that in the UK. I mean, the incidence of cancer although there's a lot of concern, and I understand that because people have reflux, and I get asked a lot about Barrett's and cancer, and I do see patients with Barrett's. I've never seen someone with a TOF get a cancer, and the numbers that are reported in the literature is very, very low indeed. Certainly there's not enough, in my view, to justify a surveillance program. The main theoretical risk would be of a cancer called adenocarcinoma rather than squamous cell cancer, although those few cases that have been reported in the literature, I think were sort of half of them were squamous cell cancers, half of them adenocarcinomas. So no, I mean, I think I think doing an endoscopy every 3 years, if you haven't got Barrett's or anything, would be excessive in my view. And there's certainly no evidence that I'm aware of to really justify doing that, because they're not very nice things. And the incidence of cancer remains very low.
Okay, well, that must be sort of encouraging news for many people on the call, I would think. I think we have one plea here from somebody whose daughter is 15 and would like to hear from other adult TOFs. And I think the answer to that is that TOFs has got a Facebook group for those people to talk to each other, and this call is perhaps not a suitable medium for such a thing. So maybe we better move on to number 25 as a question. The cytosponge. Could that be of some use for adult TOFs as a simplified alternative to an endoscopy?
Yeah, that's a great question. So for those that don't know, cytosponge is a pretty new invention. It involves swallowing a little sponge on the end of a thread, and then you sort of pull it back, and as it comes out, it expands when it's down the stomach, and as it comes out, it brushes the wall of the esophagus, and some cells come off with it, and then you can analyze the cells in the lab and see if there's any evidence of Barrett's or something like that. And it's a really, really interesting, and it saves people having an endoscopy. It's much, much more easily tolerated. There's a big trial going on in many hospitals around the country looking at how effective it can be in picking up changes like Barrett's in people who have reflux. So it's got a lot of potential, but I don't know the answer yet because that trial hasn't finished, but it may have great potential. And if it is shown to be useful in people with reflux, then it certainly should be useful in people who've had a TOF repair.
Okay, and a question there might be, is there any reason to think people who have had a repair wouldn't be able to use this for whatever reason? Maybe, I suppose, an obvious question might be joint tissue.
So if they've got a stricture, then it might be difficult to use it. But if they've got a stricture that's that's causing problems, they should be having treatment for it anyway, i.e. an endoscopy and a stretch. So the cytosponge is less likely to be helpful then.
Okay, well, that's very helpful. Thanks very much indeed. I'll pass back to Duncan now for the remainder, if I may.
Thanks, John. So my son hasn't had an endoscope since he was a baby. He's now 16, and I'm worrying about whether his esophagus or the medicine is keeping him healthy on the inside.
So I imagine he's on medicine because he has got reflux, and if that's the case, then I would recommend at some stage he has an endoscopy. It doesn't have to be now, and it can wait till he's, you know, maybe in his early 20s. But the short answer is, I think if he's got reflux, I would recommend an endoscopy to have a look and make sure he hasn't got Barrett's, because it's important to know about that so that it can be monitored and treated before it changes any further.
Okay, that's great. Thanks. What are the best methods to investigate motility in terms of choking? I'm having increased difficulties with choking on saliva, particularly both day and night, and in general with eating. What tests should be pursued, or is it worthwhile pursuing?
It is worthwhile pursuing, because it's always helpful to know exactly what's going on. It doesn't necessarily mean there's always an easy answer to it, but I'm a great believer in you don't know without investigating, and therefore, and often we can do things. The different tests that we use, there are broadly speaking, two tests. There's a barium swallow, or sometimes something other than barium, but a sort of a type of liquid that you swallow, and then you take x-rays as it goes down, and it outlines the esophagus. It shows the contractions, it shows a narrowing, and it shows if things are uncoordinated, if there's any spasm in the esophagus, and a whole host of things like that. And there's a slightly more sophisticated type of barium swallow called a video swallow, which many of you might have had, which concentrates on looking at the swallowing mechanism from the back of the mouth going through the throat into the esophagus, because often there can be problems there as well. So that's one set of investigations. We also do a test called manometry, which is when we often do in conjunction with the 24-hour acid studies that some of you will have had done. And that involves swallowing a very fine catheter with a series of pressure transducers in it. And then you swallow, and then it measures the pressures in the different parts of the esophagus, including the sphincter at the top, the sphincter or valve at the bottom, and then the esophagus in between. So those, broadly speaking, those tests can give us a lot of information about the motility and how the muscles work. And I would, if it's a problem, I absolutely would have some tests done, because we can do. I suddenly went off then. Can you hear me?
Yes, indeed. I had the same thing. Zoom seemed to go away and then bring itself back. So hopefully we didn't miss more than 30 seconds or so. No,
so in answer to that question, I would have investigations. I can't promise you there'll be something to treat, but it's what you won't know without looking and seeing what the problem is.
The question that we've got, I have a grumbling appendix with endometriosis. Is surgery an option?
Yeah, I mean, absolutely. If you mean surgery to the appendix or surgery to the endometriosis, or do you mean surgery to the reflux? I guess I don't know, but the answer is yes to all of those. I'm not sure a grumbling appendix actually exists, to be perfect, but it's a moot point that. But I mean, having had a TOF and atresia repair really shouldn't be an obstacle to having any other treatment. I mean, I don't know. You know, one of the problems some patients have is with recurrent aspirations we've heard about. So if it's affecting your lungs, that might be something for the anaesthetist to consider. But as a general rule, it shouldn't stop you having treatment for something else.
Okay, thanks for that. As people grow older, and obviously this person's 55, and they had an OA long gap, which was repaired obviously at birth. What's the prognosis for this? Will it get any worse as they get older, or does it stay the same, or what happens?
I mean, it's a good. If you had a long gap repair, then it means you've probably had colon up there or stomach perhaps. And yes, they do deteriorate over years, and many of the problems I see are people who've had colon many years previously, and the natural history of colon or stomach that's taken up to repair the esophagus, that they do become, they dilate, they get wider, they become slightly baggy, and they stop working so well. And many of you may be familiar with those problems. Now, there's often things we can do to improve the situation, and often doing stretches and balloon dilatations can really help with that, dietary modification. But occasionally, and really quite infrequently, I would do surgery to reconstruct that conduit if it was really necessary. But that clearly is really very major surgery, but can be very, very successful. And again, I'd stress it should be done by someone who's regularly doing this sort of stuff. And the comment is we can't be re-repaired in our sixes. Well, you can. I mean, it depends on many other things, but I would certainly contemplate all, major surgery in people well into their 60s and 70s if the benefits outweigh the risks. And it's coming back to what I said before, that we'd look at everyone individually and assess risks and benefits. And if the benefits outweigh the risks, then it may be worth doing something. So I certainly wouldn't say if you're in your 60s, that would rule you out because of your age.
Okay, thanks for that. How common is extremely dilated esophagus and tracheo-bronchomalacia in adult TOFs, and how should these issues be managed / treated?
So I probably can't really talk about the tracheo-malacia because I don't really deal with that. That really would be the respiratory doctors, although I have patients who've got problems with it. So I can't really answer that. How common is extremely dilated esophagus? It's rare. It's not usually the esophagus that becomes dilated, although it can be. Is often the conduit, the colon or stomach that becomes dilated, but it is sometimes the esophagus. So it's not common, but it does happen, and it can be a real problem. But we usually nearly always can do something to improve the situation. Often just with balloon stretches, sometimes surgery which is not too major, but occasionally very major surgery. So yes, there's always things we can look at trying to improve, and I would say in most patients we can do something to significantly improve the situation.
Okay, thanks for that. And just before I pass back to John for the last 3 questions, just to say to everybody, we've managed to get through questions quite quickly tonight, so we will go to the Q&A session or section of Zoom, and we'll go through the questions that people have been posing while we've been talking. So if anybody has got any other questions, we will answer as many as we can, but as I said at the start, we will finish at 8 o'clock. So please obviously bear with us, and obviously any extra after that we'll ask at another time. So John, I'm going to pass back to you.
Okay, super. Well, just another couple. So there's one about a 15-year-old son who's had a contrast study up an endoscopy 2 years ago that confirmed an esophageal shelf. Has missed out on getting an esophageal manometry done due to the pandemic, apparently, but continues to suffer daily, reluctant to eat, lost a lot of weight, up at night with heartburn symptoms. Would an esophageal manometry be necessary now, or would surgery be the next best option? Interesting comment. And if possible, perhaps via the TOFs office or something. If you know of any people in Northern Ireland who could be recommended, that would be great, because these people are in Northern Ireland.
So I guess the answer is yes to most of that. If they've described a shelf, that's usually where the repair has taken place. And what it looks like you're describing your son is a really common scenario where they have food sticking going down, possibly due to the shelf, and that's usually the repair, which can be, in my experience, very easily dilated and improved. But he's got reflux as well, and often you do see people with that combination. So and it sounds like his quality of life is very poor, so I would certainly recommend he sees someone, and it may be, and the sort of investigations I would look at doing would be a gastroscopy to have a look down on the camera, quite a contrast, he's had that, hasn't he? So
yes,
and manometry and 24-hour pH studies can often be very helpful. So yes, most of those tests probably would be appropriate to do. I mean, your son's 15, so he'd have to see a paediatric doctor at the moment. I don't know the situation in Northern Ireland. I do know a very good upper GI surgeon for adults in Northern Ireland but at 15 he'd probably have to see a paediatric specialist. So I don't have any contacts in that, I'm afraid, but TOFs may well know people out there.
Yes, I think on the paediatric side we're reasonably well covered, and I think we might contact you directly and make sure we've got the list of your contact on the adult side in Northern Ireland on our list.
Absolutely.
Okay, so thank you for that. And I think this is the last on our pre-prepared list. This is from someone who says, I have an esophageal shelf and continue to have reflux problems. I take 30 milligrams lansoprazole daily, plus Gaviscon dual action tablets and erythromycin 3 times a week. Food intake is just 1 meal a day. I drink lots of water and take 5 Laxido sachets daily. Yet I continue to be constipated most days. Is that normal?
I don't think that's likely to be related to your TOF repair in the past. I mean, it is well. I mean, I'm not a bowel expert. I really stick to the upper end of things. So I'm not really someone who can advise a lot on constipation other than a general sense. But I know it's quite common for people who've got motility problems with their esophagus and stomach, and it absolutely sounds like you have. It's quite common for those motility problems to affect the bowel as well. So it sounds like there may be a motility problem affecting the bowel as well, leading to constipation. And again, it would probably be sensible just to see someone about that.
Okay, well, look, thank you for that. I'll pass back to Duncan now to see if he can pick out the most relevant questions that have come up on our chat line and put some of those to you. Thank you.
Thanks, John. Right, so I'm going to try and get through as many questions as I can. So, Nick, we're going to have to try and keep the answers quite short.
Yeah.
This one I don't think is that relevant for you, but I have a 10-month-old baby. When should medication be reassessed? So, I mean, that could apply to adults as well. And then the second part of the question was, he's had 6 dilatations now. Will there be a moment when he won't need any dilatations? I can answer that one. It's when they can swallow normally and not struggling with it is the main answer. And please don't worry about the number of dilatations, because my daughter had nearly 30. So, you know, it is when the consultant and yourselves think it's right, and you will know it's right. So what about medication? When should it be reviewed?
I mean, again, I can answer from an adult point of view. I think you should have a review by your GP or specialist on a regular basis, but, you know, maybe once a year, that sort of thing. It may be more frequent for babies, and probably would be more frequent for babies actually, but certainly for adults I'd recommend a sort of an annual review just to check you're on the right medication and everything.
Okay.
And I'd agree with your comments about dilatations, that they tend to be less and less frequent as you get older and much less common in adulthood.
Okay, have you heard of vocal cord paralysis before in TOFs?
So no, I mean, yes and no. So I've heard of people having real, and I've got one patient who's a very difficult problem, who has got a lot of vocal cord problems related to a combination of tracheo-malacia and reflux affecting the vocal cord. So I have seen reflux that's so bad that it causes the vocal cords not to work well, but I've never seen them completely paralyzed. As a paralysis usually means the nerve is not functioning, and I haven't seen that related to TOF. I mean, I could imagine it might happen as a complication during a repair of a TOF, because the nerves to the vocal cords do go in a strange course in the chest. So it could be related to that, I guess, but not otherwise.
Okay, I'm sure a lot of people will be interested in this one. How do I know which upper GI surgeon has OA experience and to ask my GP to refer to? And subsequently, following on from that, how do people get themselves referred to yourself?
I mean, so as a starting point, I would suggest the GP, he won't know, he or she will not know who has the expertise, but he or she will know who the local esophageal expert is. So each hospital will have specialists who are known to deal with esophageal problems. Many of them won't have seen TOF patients, but that would be a good starting point. And even if they're not the right person, then they may know someone like me or one of my other colleagues who can see patients. In terms of being referred to me, and I do see people from all over the country, you have to get your GP to agree to it, basically. That's not my demand. That's they're the funding requirements and the way the NHS works. But if your GP agrees that they're happy for you to go out of area, then I'm happy to see you.
Okay, thanks for that. Another one. Are hiccups an ongoing sign of reflux?
Yeah, they're associated with reflux, but hiccups are involuntary contractions of the diaphragm, and so if there's anything pressing on the diaphragm, like a hiatus hernia or food getting stuck down there, that can absolutely precipitate hiccups. But it's that, so it's associated with problems that cause reflux, but it won't actually be the reflux itself doing it.
Okay, all right, thanks for that. Right, I'm going to say thank you very much for your time tonight, Nick, because obviously we're almost at 8 o'clock, and I did say we were going to stop at 8 o'clock, and we know how busy you are. So, you know, as TOFs, we are eternally grateful for the time that you've given us tonight. And obviously, there are a lot of questions in the chat, in the question and answer box. So we'll get a note of them, and perhaps then we can get the questions to you, and then we can get the answers back to everybody else.
Please do send them to me. I'll be very happy to answer them all individually. So because there's a lot of questions that haven't been answered.
Yeah. So, like I said, thank you for your time, John. Thank you for your assistance again tonight. And obviously, if you are watching this back on through YouTube, on our website and everything else, please remember to hit the like button in the top hand corner. And thank you very much for joining us. And hopefully we'll see you again sometime soon. Thank you all. Good night.
Great pleasure.
Bye now. Bye.